Bismillahirrahmanirrahim. Today's topic is diuretics, and if we define diuretics are those drugs which induce a state of increased urine flow by altering renal ion transporters. So, two things are important for in this definition. One is that it is the state of increased urine flow. It's more than normal, which normally a patient has an amount of urine, it almost doubles the urine output. How does a diuretic drug do that? Simply because it alters the sodium entry at different sites in the nephron. It increases the sodium output into urine, which is also called natriuresis. Natri means from natrium, it's for sodium, and natriuresis, the excretion of sodium in urine. Okay, well, what happens if sodium goes into the into the into the urine? So wherever the sodium will go, water will follow it. So simply, if sodium is excreted in the urine, then the water will also be excreted from the body into the urine. So that is how diuretics act in the body. Not all the diuretics actually alter this sodium transporter. Certain diuretics have some of the diuretics, so certain diuretics have effect on water reabsorption, while other antagonize aldosterone, and some yet others have other target organs or the target enzyme, you can say, for example, carbonic anhydrase. As we will see further into different classes, so you'll come to know the mechanism of action of these diuretics. For understanding, or for having a better understanding of the diuretics, we must first recall the physiology. So these are, if you remember, this is a nephron, and these are different parts of the nephron, starting from the proximal convoluted tubule, that is also called as PCT. Then there is the first part is Bowman's capsule, which has a tuft of capillaries called glomerulus. Then from the Bowman's capsule, it takes convolutions are there, which are called proximal convoluted tubule. So this is also called PCT. Then there is loop of Henle. It has two parts. One is a thin descending, then it is thin ascending, which is climbing up. Then there is thick ascending part. Then here you can see the distal convoluted tubule is there. There are different convolutions. Then there is collecting tubule, then collecting ducts. So that was a short remembrance. So what is the importance of sodium and ECF volume? So as you know, the sodium is an osmotically active substance. It means wherever the sodium will go, it will attract water. So anything that attracts water is called osmotically active. or which promotes osmosis. So there are different transporters or different transporter proteins in basolateral or apical side of the membrane which actually transport sodium. So what is ECF volume? ECF volume is extracellular fluid. So what is extracellular fluid? So here, for example, this is the vein or the vessel, you can say. It contains plasma. Here is interstitium or interstitial fluid, you can see. Then here is the tissue, or these are the cells. So any water that this is interstitial fluid, this part is ICF, well, bear with me for the writing. So here, plasma and interstitium or the interstitial fluid are collectively called extracellular fluid. So what actually happens? So any fluid that is present within the cell is called intracellular fluid. So in a normal 28 in a normal 70 kg man, the weight should be 70 kg, healthy man, this ICF is 28 liters. While the interstitial fluid is 11 liters, plasma is around 3 liters. So as a whole, this makes up 28 plus 11 plus 3 is around 42 liter volume. So what actually happens if the shifting between these body waters is continuously occurring? For example, if this goes down, for example, for 2 liters, this is a huge loss. I'm just giving you an example. If this goes down to 2 liters, it means there is a shortage of 1 liter. Then some of the water, almost 1 liter, will move from here, from interstitial fluid to plasma. And from then there is a shortage in interstitial fluid, then the water will move from the intracellular fluid to the interstitium. If that loss is continuous, so this process will be continuously occurring. Well, we see this is how we can lose water. If this plasma has sodium as well, this sodium is also being lost, then this loss will be doubled. So this is how extracellular fluid is important. So what actually happens if there is an excessive sodium retention? If sodium is retained within plasma or in ECF, then it may cause edema, ascites, pulmonary edema, and hypertension. So, excessive sodium retention is a major cause of many diseases. Edema is the accumulation of water in interstitium. Here are the cells. This is the blood vessel passing through these cells. Just understand these concepts here, because throughout the presentation these concepts will be used. How the diuretic will act. These are the body cells, for example. Here if you see, here are the ions, or what this sodium retention can cause. If the sodium is retained within the cell, if sodium, the quantity of the sodium is high in extracellular fluid, what it can cause? It can, because I just told you sodium is osmotically active. Osmotically active means it can attract water to itself. Wherever the sodium will be, it can attract water. For example, if sodium is in a greater quantity here, then water from here will move to this side, and this will cause accumulation of water, greater accumulation, because already water is here. It's a fluid chamber. The interstitium, this is the interstitium here. This is the plasma. This is interstitium here, and any water that is present here, it's ICF here. ICF, 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 ICF. Collectively, all the water, all the cells have water. If you accumulate that, that becomes around 28 liters. But ECF, interstitial fluid, will be increased, or between the, so this is called edema. So you can see what can happen. This accumulation can happen if the sodium retention means sodium will be retained within the ECF. Ascites, again the accumulation of water in peritoneal cavity. This may be due to liver disease, pulmonary edema, and hypertension. Hypertension is, again, sodium is linked with hypertension. Greater sodium level may increase hypertension, may cause hypertension. So optimum sodium level can be maintained by a mechanism called like sodium balance. With how can it be achieved? It can be only achieved, the amount excreted daily must equal the amount of sodium ingested in the diet. For example, if you have consumed 25 mg in a day, then you must excrete out 25 mg, so thereby the sodium level will remain at a constant level. But if you consume 30 mg and you excrete out 25 mg, it means you are having a 5 mg that will retain in your body. So ultimately this may cause sodium retention, and if sodium retention occurs, all these things can happen. So these are the different diuretics which act on different segments of you can say nephron. So here this arrow shows the reabsorption. The different ions are being reabsorbed in these segments. Here is a glomerular filtration occurs here. The fluid comes, is rich in substances. 99% of the load is reabsorbed. Reabsorbed means that goes back to the blood. Okay, well, this here in the proximal convoluted tubule we have reabsorption for sodium chloride, sodium bicarbonate. So emphasis is on sodium. Here again sodium. Then it is water. Water is also reabsorbed. Then it is the loop of Henle, thin descending loop of Henle. This is exclusively for water. Here the water channels are there which can cause reabsorption of water in the loop loop of Henle. Then at the ascending thick limb of loop of Henle, there is a hole there are many you can say ions that are being reabsorbed. For example, chloride, then potassium, sodium, magnesium, calcium is there. Then there is distal convoluted tubule. The distal convoluted tubule has sodium chloride. Then calcium is being reabsorbed. Then there is collecting tubule. Potassium and hydrogen ions are excreted out from the body. There are specialized cells in a collecting tubule which can carry out this function. And here sodium chloride under the influence of aldosterone is being reabsorbed. Again, potassium and hydrogen are excreted out or secreted into the tubule. Here is water is being reabsorbed under the influence of antidiuretic hormone. So well, all these for example, here you can see on this segment proximal convoluted tubule, acetazolamide acts and causes diuresis. Some of the loop diuretics also act on the proximal convoluted tubule to block water reabsorption. Well, some of you can say diuretics like adenosine can also cause blockage of in glomerulus or in proximal convoluted tubule. Then then osmotic agents act on loop of Henle, while loop diuretics act which are called furosemide, important for you, act on thick ascending limb of loop of Henle. Then thiazide diuretics act on this reabsorption, sodium and chloride, while aldosterone antagonists act on this side and block the reabsorption of sodium and chloride. Then there are ADH antagonists, they act on ADH, they block anti-diuretic hormones, so ultimately they block water reabsorption. So if you see the structure of the nephron, here this is a arteriole in the glomerulus, this is the afferent arteriole, and this is the efferent arteriole. So once this leaves here, it is wrapped around the nephron, and this supplies blood, then it collects the blood from. So anything that comes from the tubule into this blood supply is called tubular reabsorption, and anything that comes from this blood supply or this blood vessel into the tubule, this is called tubular secretion, and this is glomerular filtration. So at the end of this tubule, anything that comes along the water, this will become the urine or the concentration of the urine. So what actually diuretics do? Diuretics double the urine volume. So this is the small portion of the kidney. This is the one nephron. If we see the wall of the nephron, if this is the nephron, and nephron has a membrane, a wall. So if you see or magnify this one chamber here, it will look like this. The cells are like this. So we will see in like couple of minutes like this. If you go like this is, or these cells are from the nephrotic wall. So we have magnified, and these membranes or the nephrotic membrane or the nephron membrane have different transporters or transporter proteins. These can transport different ions. For example, sodium is being reabsorbed while potassium is being secreted or excreted out. So anything that the arrow is showing from left to right, remember, in all the next slides, any substance that is moving from left to right, from here to here, will be reabsorbed back into blood. For example, it means from the tubule into the blood. Anything that is, or any substance that is coming from right to left, that will be secreted into the nephron and ultimately excreted out from the body. In this diagram, for example, sodium is being reabsorbed while potassium is being excreted out, while water is being reabsorbed, potassium is being reabsorbed, while hydrogen ions are being excreted out. This is a blood vessel. So there are two things which you have to remember. The side of the membrane. If this is the nephron, this is the one side and this is the other side. How you will find these sides in the textbooks? If I say two names, basolateral or then the apical membrane. So which side will be apical and which side will be basolateral? So basolateral side is always this side. This is from the base, and lateral side is towards the lumen. While apical side here in the nephron, just remember this is the apical side, this is the basolateral side. If this is the segment or cell of the nephron. So diuretics have different functions. They can be used in edema, because we just saw that in edema occurs due to sodium retention. So diuretics alter the sodium level, or they excrete the sodium, and ultimately will cause the relief of edema. So sodium is also related to the hypertension, for the development of hypertension. So if we excrete out sodium, so these diuretics can also be used in hypertension. Here, this is the basic structure again. Just to make an emphasis, this is the blood vessel. Which blood vessel? This blood vessel. Any of the segment could be there. This is the blood vessel. This is the nephron, magnified nephron. So this is one side of the nephron, this side only. So this is this lumen. So this, the middle one, is called unilumen, and this wall of the membrane is magnified here. This is made up of cells, epithelial cells. So here is the interstitium. Interstitium is the intermediate between the blood vessel and the cell, or the plasma, and the cell, sorry. So this is, so anything that goes from here, from left to right up to the blood vessel, this is called reabsorption. Anything, any substance that comes from the blood vessel in across the luminal cell and into the lumen, this is called tubular secretion. Just remember this. I am emphasizing on these things. So basic pharmacology of diuretic agents we will take up in next lecture. Thank you very much.